Hi, my name is Dr. Calynn Lawrence, and I am the founder and programming director of the Holistic Healing Source for Marginalized Society. I'm a board certified forensic traumatologist and a doctorally prepared pastoral counselor and globally accredited holistic medicine researcher. Thank you for joining us. Let's go ahead and get into this presentation. Let me share my screen. Navigating medical mistrust among marginalized populations, the roots and the remedies. This presentation is very near and dear to home as a Black woman who grew up in a low income, majority minority community, and someone who has fought tooth and nail to get people close to me to be open to the idea of getting help. Medical mistrust, a deeply held skepticism toward healthcare providers, medical institutions, and clinical authorities, represents one of the most critical barriers to health equity today. Far from being an irrational or unfounded attitude, medical mistrust is an understandable protective response to historical exploitation, systemic racism, everyday discrimination, and a negative personal encounter with healthcare systems and settings. Across diverse marginalized communities, including BIPOC, LGBTQ, low income, unhoused, and female patients, medical mistrust severely compromises healthcare utilization. It leads to delayed care seeking, reduced adherence to treatment regimens, underutilization of preventative screenings, and reluctant to engage with mental health services. Addressing this crisis requires healthcare systems to shift away from pathologizing mistrustful patients and instead focus on diagnosing and remediating the structural and interpersonal conditions that produce mistrust in the first place. The deep roots of medical mistrust. Understanding medical mistrust requires examining the intersecting historical, structural, and interpersonal drivers that generate and sustain suspicion toward medical institutions. These root causes manifest in care avoidance, underutilization of preventative medicine, and reluctance to access necessary health continuums. First, historical injustice and scientific exploitation. In marginalized communities, particularly within African American populations, medical mistrust is anchored in a long history of institutional betrayal, racism, and unethical medical experimentation. Historically, Black Americans were subjected to medical exploitation as involuntary test subjects to advance modern clinical knowledge without receiving equitable care in return. This legacy of harm, combined with ongoing racial disparities and lack of diversity among healthcare professionals, fosters enduring skepticism regarding whether medical systems truly prioritize Black lives. Consequently, historical trauma serves as a lingering deterrent to seeking both physical health care and clinically necessary mental health treatment. Everyday discrimination and intersectional stigma. Medical mistrust is continually reinforced through daily encounters with discrimination outside and inside the clinic. Perceived everyday discrimination, whether experienced in school, employment, housing, or public spaces, strongly correlates with group based medical mistrust. When individuals encounter societal prejudice based on their race, ethnicity, sexual orientation, housing status, or history of substance abuse, they naturally anticipate similar mistreatment from healthcare providers. For individuals holding multiple minoritized identities, intersectional stigma compounds this dynamic. For instance, gay, bisexual, and other men who have sex with men who are newly diagnosed with HIV navigate overlapping stigmas tied to sexual orientation, race, and health status. Internalized HIV stigma directly predicts elevated sexual orientation-based medical mistrust, illustrating how broader societal homophobia and illness-related shame degrade trust in healthcare networks. 3. Epistemic injustice and dismissive provider behavior. A primary catalyst for medical mistrust is epistemic injustice, a phenomenon occurring when patients are insufficiently believed, discredited, or improperly understood simply because they belong to a non-dominant social group. In clinical interactions, epistemic injustice manifests as providers dismissing physical symptoms, minimizing pain, or attributing complex medical complaints to emotional instability, weight, or drug-seeking behavior. When patients voice genuine health concerns only to be labeled histrionic, ignored, or subjected to coercive medical interventions without informed consent, the healthcare encounter itself becomes traumatizing. Rather than feeling cared for, patients experience a secondary harm that leads them to view medical institutions as hostile or coercive entities. Manifestations across marginalized populations. The consequences of medical mistrust manifest uniquely across distinct vulnerable groups, highlighting the urgent need for tailored clinical interventions. Firstly, maternal mortality and postpartum care avoidance. The United States faces a severe maternal mortality crisis, with maternal death rates 3 to 4 times higher for Black women and up to 3 times higher for non-Black Latinas compared to white women. Crucially, the Center for Disease Control and Prevention, the CDC, estimates that over 80% of maternal deaths are preventable, with more than half occurring in the fourth trimester, quote unquote, the postpartum period after a patient leaves the hospital. Qualitative research reveals that medical mistrust is a primary factor keeping postpartum parents from returning to the hospital when life-threatening complications arise. Patients who experienced birth trauma, obstetric violence, non-consensual procedures, or racial bias during delivery frequently decide that returning for care poses a greater threat to their safety or dignity than staying at home. Statements such as, "Why would I go back there? They don't care about me anyway," summarize how traumatic clinical experiences convert single medical encounters into long-term institutional mistrust. This creates a dangerous postpartum care avoidance cycle. Traumatic birth experiences and implicit biases lead to epistemic justice, or injustice rather, and a lack of informed consent, which in turn fosters severe medical mistrust that results in patients avoiding care even when faced with life-threatening complications. 2. Young Latinx adults and regional health disparities. Among young Latinx adults, particularly in rural or non-traditional immigrant settlement areas, medical mistrust poses a significant challenge to accessing sexual, reproductive, and general health services. Psychometric testing of the modified group-based medical mistrust scale among young Latinx adults demonstrates that mistrust is structured around two key dimensions: suspicion of medical motives and perceived unequal care. In these communities, everyday racial discrimination is the strongest predictor of medical mistrust. Furthermore, cultural factors interact with mistrust in nuanced ways, such as machismo. Traditional machismo values, often emphasizing hypermasculinity or strict gender roles, are positively associated with medical mistrust, particularly among Latina women who may navigate a healthcare system dominated by non-Hispanic white male providers. Familismo. Conversely, strong familismo values emphasizing family support, interconnectedness, and collective well being, show potential as a protective cultural asset that buffers against medical mistrust. 3. People experiencing homelessness. People experiencing homelessness face cancer incidence rates 4 times higher and cancer mortality rates twice as high as stably housed populations. Despite the availability of free or low cost preventative services such as state funded breast cancer screenings, usage remains dangerously low among unhoused women. Qualitative studies show that people experiencing homelessness encounter persistent stigma, dehumanization, and dismissive attitudes from healthcare staff regarding their housing status, mental health, or history of substance abuse. Experiences such as having pain dismissed as panic attacks or feeling coerced into medical decisions create an environment of suspicion. For these people, medical mistrust reinforces the perception that healthcare spaces are unsafe, causing individuals to prioritize immediate survival needs over preventative cancer screenings. 4. LGBTQ plus individuals and sexual or gender minorities. For queer patients in the broader LGBTQ plus community, medical mistrust is deeply rooted in a history of medical pathologization and systemic discrimination. Historically, homosexuality was classified as a mental disorder until 1973, and sexual minorities faced intense discrimination from healthcare providers, researchers, and policymakers during the height of the HIV/AIDS epidemic. Today, sexual and gender minority groups continue to experience severe healthcare disparities driven by non-inclusive policies and a lack of holistic, culturally competent care. These historical and contemporary harms create a hostile social environment that severely impacts care-seeking behaviors. For example, among newly diagnosed HIV positive, gay, bisexual, and other men who have sex with men, individuals frequently navigate intersectional stigma related to their sexual orientation, race, and HIV status. High levels of internalized HIV related stigma directly predict greater sexual orientation based medical mistrust. This mistrust manifests in detrimental health behaviors, including lower rates of HIV testing, suboptimal adherence to antiretroviral therapy, and overall reduced utilization of life-saving medical care. Remedies, transforming systems to restore trust. Mitigating medical mistrust requires structural, institutional, and interpersonal reforms aimed at creating trustworthy healthcare environments. Systemic transformations must address clinical interactions, care delivery models, cultural assets, and overarching health policies. 1. Embracing epistemic humility and patient-centered communication. Healthcare institutions must transition from demanding patient trust to earning trustworthiness. Providers must approach patients with epistemic humility, acknowledging that patients possess valid expertise regarding their own bodies and lived experiences. Key clinical practices include active listening and validation. Clinicians must actively listen to patient concerns, validate their self-reported pain, and refrain from rushing or dismissing complaints. 2. Transparent, informed consent. Medical interventions, risks, and options must be explained in plain language, ensuring patients retain body autonomy and feel included in the decision making. Lastly, framing questions with context. When assessing sensitive topics such as functional decline, substance use, or mental health, providers should explain why questions are being asked to avoid appearing accusatory or invasive. Next, collaborative and community-based care models. Structural barriers to trust can be dismantled by reconfiguring how care is delivered, such as midwifing the healthcare system, Expanding access to certified midwives and professional doulas provides continuous one-on-one relational support during pregnancy and labor. Doulas act as trusted advocates who translate clinical language and bridge cultural divides, significantly improving birth satisfaction and safety. Expanding community birth centers. Out of hospital birth centers offer low intervention, personalized care environments that reduce anxiety and foster rapport, particularly for low risk pregnancies in rural and underserved areas. Integrating peer navigators. For populations like people experiencing homelessness or newly diagnosed men who have sex with men, peer navigators and community health workers who share lived experiences can assist patients in navigating complex medical systems, reducing fear and stigma. Leveraging social support and cultural assets. Research confirms that social support plays a critical mediating role in mitigating medical mistrust. Among newly diagnosed men who have sex with men, perceived availability of social support attenuates the negative impact of HIV-related stigma on medical mistrust. Interventions designed to strengthen peer networks, group counseling, and community-based support systems can rebuild trust across marginalized groups. Furthermore, healthcare initiatives targeting Latinx communities should actively integrate positive cultural assets such as familismo, involving family units in health education and care planning to foster reassurance and safety. Workforce diversity and systemic policy reform. Long-term restoration of trust demands systemic policy intervention and institutional accountability, such as diversifying the healthcare workforce, increasing racial, ethnic, linguistic, and gender diversity among physicians, nurses, and specialists creates clinical environments reflective of the communities served. Institutional grievance mechanisms. Hospitals must establish clear, accessible, and transparent grievance processes where mistreatment, non consensual procedures, or discriminatory behaviors are investigated and corrected. Taking complaints seriously and offering genuine institutional atonement can rebuild trust even after severe clinical errors occur. Lastly, policy and financial restructuring. Policy initiatives such as expanding Medicaid coverage for postpartum doula care, raising reimbursement rates for rural safety net hospitals, and supporting federally qualified health centers are necessary to eliminate structural care deserts and ensure accessible, high quality care for all. In conclusion, medical mistrust among marginalized populations is neither an accident nor an unchangeable trait. It is a direct reflection of historical trauma, ongoing systemic inequities, and dismissive clinical encounters. When healthcare systems fail to listen to women, dismiss racial minorities, stigmatize unhoused individuals, or marginalize sexual minorities, patients protect themselves by withdrawing from care, sometimes with fatal consequences. Overcoming medical mistrust requires moving beyond superficial fixes and engaging in deep structural transformation. By embedding epistemic humility into clinical training, integrating collaborative care models, leveraging community social support, diversifying the healthcare workforce, and enacting supportive health policies, healthcare institutions can transform into spaces of genuine safety, healing, and equity. And here are the scientific references, part 1 and part 2. Thank you for listening.